Take a look at this transesophageal echocardiographic clip. The left atrial appendage, or LAA, is clearly demonstrated here. The left atrial appendage is a small ear-shaped pouch that projects from the main body of the left atrium. It lies anteriorly in the left atrioventricular groove and is closely related to the left circumflex coronary artery, the phrenic nerve, and the pulmonary veins. But the LAA is much more than an anatomical appendage. It contains atrial natriuretic peptide, or ANP, and therefore has important mechanical, endocrine, and hemodynamic functions. The LAA is compliant, so it can act as a reservoir or a decompression chamber, particularly when the left atrial pressure rises. This is a three-dimensional view of the LAA, as if you were standing in front of it and looking directly into its orifice. Interestingly, the LAA is not a standardized little tube. Its shape varies dramatically from patient to patient. The classic four morphological patterns are chicken wing, windsock, cactus, and cauliflower. Windsock and cauliflower morphologies are more associated with thrombus formation than chicken wing morphology. When atrial contraction is lost, such as atrial fibrillation, blood flow slows down. Red blood cells aggregate, producing a spontaneous echo contrast that often described as smoke. Spontaneous echo contrast and sludge are not identical to thrombus. However, they indicate a highly thrombogenic environment. One of the most useful echo parameters here is the left atrial appendage emptying velocity. An LAA emptying velocity less than 20 cm per second is strongly associated with blood stasis and a higher likelihood of LAA thrombus. When stasis becomes sufficiently severe, thrombus can eventually form. LAA clot formation is driven primarily by blood stasis and the patient's underlying prothrombotic substrate, not by patient's symptoms, such as palpitation. So, the absence of symptoms does not mean the absence of thrombus. And now, I would like to challenge a common clinical assumption that cardioversion is safe because the patient says the AF started less than 48 hours ago. I have personally seen tragic cases of stroke occurring after cardioversion in this setting. In fact, thrombus formation in LAA depends not only on duration of AF, but also on a thromboembolic risk, LA and LA appendage enlargement and dysfunction, underlying structural heart disease, previous episodes of AF, atrial myopathy, and the presence of spontaneous echo contrast. An LA appendage thrombus can already exist when AF is first detected. Therefore, never confuse newly detected AF with newly developed AF. The arrhythmia may have started much earlier than the patient noticed it. AF can be clinically silent but biologically active. A patient may have paroxysmal AF without symptoms, persistent AF with surprisingly few symptoms, or even a patient with apparently newly detected AF may already have an LA appendage thrombus. The clock starts when AF actually begins, not when the patient first feels it. And unfortunately, those two moments may be very different. A short apparent duration reduces the risk of thrombus formation but does not eliminate the possibility of LA appendage thrombus. The decision to proceed directly to cardioversion should therefore take into account the patient's thromboembolic risk, anticoagulation states, and the clinical setting. In a patient in whom the duration of AF is uncertain and there are significant thromboembolic risk, transesophageal echocardiography to exclude LAA clot is very useful when early cardioversion is desired. The ECG tells us the rhythm. The history tells us when the patient notices it, but the TE tells us what has been happening inside the atrium. Surgical closure of the LAA does not necessarily eliminate a thromboembolic risk. Even after surgical closure, incomplete closure, recanalization, or a residual stump or pouch can leave a thrombogenic cavity where thrombus can still form. And cardioversion does not immediately eliminate the risk either. After restoration of sinus rhythm, the atria may remain mechanically dysfunctional for some time, a phenomenon known as atrial stunning. In other words, the ECG may show normal sinus rhythm while effective mechanical contraction of the atrium has not yet fully recovered. Blood stasis can therefore persist and thrombus formation may still occur. So, to sum it up, the 24-hour or formerly 48-hour concept should not be regarded as a magic biological threshold. There is no biological clock inside the left atrium that suddenly makes cardioversion safe at 23 hours and dangerous at 25 hours. Or under the former 48-hour paradigm, safe at 47 hours and dangerous at 49 hours. Time matters, but time alone does not determine a thromboembolic risk. That is an important correction to the traditional teaching. And one of the reasons contemporary guidelines have become more cautious about using a simple time-based rule as the sole basis for deciding whether cardioversion is safe.